All right, recording has started just for everyone. Welcome today. Go ahead and sign in the chat box. Rename yourself in the list as usual. And today you will see some photos interspersed in the presentation, so hopefully you see some of yourself. If you do, give us a shout out in the chat box. If you see yourself, let us know. All right, today I do want to see everyone's face, so turn on your cameras. We're going to get a snap picture of everyone's face. Go to my gallery view. So turn on your cameras, say hello, wave, let's see some energy. Let's see, Jackie, turn on your camera. Dr. Matsvangwa, turn on your camera. Jackie, there you are. Stefano, all right, I need to see a few more cameras on. Memory, I see your camera. Chietza.
Teresa, Permit, please turn on your camera if you can.
All right, we've got one more second here to turn on your cameras. I see Priska, I see the CDC background. All right, so we're going to snap our screenshot today. So 1, 2, 3, look happy. All right, awesome. Great to see everyone today. I will quickly save that photo. And there we go. All right, fabulous. Happy to see everyone's smiling face today. All right, I want to give a chance for Fortunate and her team to say hello to us today and welcome us. Fortunate, whoever you have there with you, give us.
I'll ask Dr. Mchanga to do that for us. Thank you.
Okay.
Oh, hello everybody. Hello.
Hello, Junior.
Good afternoon, Dr. Junior. Good to see you.
Nice to see you too. It's a pleasure to be on this call once again. And I know it has been a long walk with all its humps and bumps, but we've managed to pull through. Thank you to Katie. Thank you to Barbara for the resilience. Thank you. I saw Dr. Kabo was on there. And thank you to CDC for all your support. Thank you to all the participants who have enjoyed going through this new way of doing business, the virtual one. It seems like we are now enjoying it, but initially, of course, it really was an issue. But I'm so happy. I'm excited. And on behalf of BRTI, we really appreciate all the efforts to make this a success. Thank you all, and over to Barbara and Katie.
Thank you. Wonderful to see you again and hear you. I remember all those days through the pandemic. You were faithfully here with us. Again, we're going to see some photos today. So if you see yourself, type into the chat box and let me know if you remember where the photo was taken.
I don't remember. Where is it?
That was, I think that's Hopely Clinic.
Wow.
So for today, wow, we are finally here to review and celebrate the accomplishments of the LARC CLI initiative, and our expected outcome is a successful completion of this initiative. Our deliverables from last time were the end of the cohort survey. 54 of you took that survey, and we'll share that today, and then your final reports. So we do have some data to share and some final reports, best practices. Here's our agenda. We have a lot to cover today. We've given ourselves a couple of hours. After our welcome and introduction, we'll see the data, and you will not believe the data. So Mr. Japhet Mabuku has done a great job. I'll share a few of the best practices that we've gained, interventions that people have utilized. So we'll share those today. And then Dr. Katie and I will share the results from the LARC survey that you took. Matron Makato will give us an update on our dashboard. We have some certificates of participation and awards to come, so looking forward to that. We have our leadership. We'll have an opportunity to give some closing remarks, and then we'll end with an appreciative debrief, and I promise we will end on time. So this is it, the end. There are no more, no more to announce. This is our final webinar, and so thanks for joining us today. Again, if you see yourself in any of these photos, tell us hello and tell us maybe where the photo was taken. Anybody know where this one was taken? All right, you can type in the chat. All right, so I am now going to turn the time over to Japhet for our final data. So I will stop sharing, and I think, Japhet, I've made you a co-host, so please go ahead and share with us these results so we can celebrate.
Okay, thank you, Katie and Barbara, and thank you all for taking part in today's webinar. I'll walk you through the results for the 3 M's that we are prioritizing. Just a moment, let me open. Okay, yeah, so here we are. So I will be sharing the performance for the 3 M's that we were working on with the facilities, and also the 2 M's that we were working with the lab. But let me start by giving a disclaimer that this data we still need to ensure that it's complete. There are some few facilities that have not submitted, or we are still in the process of cleaning the data, so we have not included their data in the presentation. And maybe lastly, just to mention that when I was working with the RIDH lab and the NMRO lab, it got corrupted. So I will share the final presentation with the BRIDH and NMRO. So we have the facility teams plus PSI lab. So in terms of for the facility teams, we're prioritizing 3 aims. Number 1, it was to do with the documentation of results slip in the green books or in the patient care booklets. Number 2, we're looking at missed appointments for clients with high viral load. So we are saying of the clients that had a scheduled appointment for the high viral load, be it EAC 1 up to 3, as well as the repeat viral load, how many of our high viral load clients missed their appointment? And the last one that we went on in the last 2 months, it was viral load coverage. So I'll be presenting data on those 3 M's under the facility performance. Then for the lab, we'll be looking at viral load, turnaround time, and also the rejection rates in the lab. So in terms of documentation of viral load and the patient care booklets, This is the performance. So we started by collecting baseline data. We are looking at the cohorts from October to March 2019 to establish the baseline. And from the baseline, we also use the same data to calculate the mean performance based on the baseline data. So from February, from November, we started implementing November 2019 when we had our first learning station. And this is the performance for the facilities. We were hovering below the mean that was calculated based on the baseline performance. But when we moved to around February, when we had our second learning session, our performance went above the mean, which was around 79%, and our target was to achieve 90%. So if you look at from around April, May, June, we were above the target, which was set during the first planning meeting, which was 90%. So that's it in terms of documentation of viral load results. So this is a heat map which shows facility performance across the 3 districts that we are implementing, Chitungi, Harare, and Seke. The greens, it shows that facilities were doing quite well in terms of documentation of viral load. Yellow, amber, they were in the middle. Then the reds shows that facility were struggling with documentation of viral load results. So when we started, most of the facilities were in the amber, red areas, but when we moved to around February, most of the facilities were in the green and amber, which shows that facilities were doing or putting some hours in terms of trying to improve the indicator or the metric that we are focusing on, viral load, documentation of viral load results. Moving on to clients that missed scheduled appointment. Again, we collected baseline data from July 2019 to December 2019. Our median performance based on the baseline data was around 34%, which means that 34% of the clients that had a scheduled viral load appointment missed that appointment. But if you look at from February, when we started prioritizing the metric, the performance went down, which is a plus from our end, because with this indicator, we expect to have fewer and fewer people or clients missing their appointments. And in June, we had a 34%, but we will then also share the data up to October. But it shows that we have almost 5 data points which are below the median, which shows that something was being done by the facility team. So if we have consecutive points which are either above or below the median or the mean, it shows that whatever interventions or efforts that have been put in place by the facilities, they are yielding the desired result. Then looking at the heat map in terms of missed appointments, that's the performance for the facility. So in this case, if we have the 90% and so forth, it means most of the clients that had scheduled appointment missed their appointment. Again, if you look at in the last 3 months, April, May, June, yes, we had more of the facility from the amber, and yeah, maybe 50% in the amber, maybe 50% in the red, and just a few were in the red, the likes of Zengeza Clinic, although in June, they managed to contain the number of clients who have missed appointment. So the facilities that have blank or that have got white color background, we are still working on the data to try and polish out the data for those respective facilities. So we share a more refined and a more complete presentation with the facility performance. So in terms of viral load coverage, we also, again, collected the baseline data. We worked with the implementing partners. They supplied us with quarterly performance based on the data that they are collecting from the facilities. So we collected data from Q1 in 2019 to Q2 in 2020, so that we have an understanding in terms of where we are in terms of viral load coverage. And from the data, it shows that about 48% of our clients had a viral load test done for viral load collection coverage. We're looking at from sample collection up until the result slip or the result is documented in the green book. And again, from September and October, we also noticed that our performance was above the median, which is 48%, although I may need to remind the audience that we only managed to work on this indicator for only 2 months. So we didn't have enough time to hammer more on the viral load coverage. So in terms of the performance for the facility, this is the performance for the facilities. I think there are just a few facilities that were in red, that we had some challenges in terms of achieving the 80% viral load coverage. So the target for AIDS and TB in terms of viral load coverage was 85%. We revised down to 80%. So those that are above 80% are the ones that are in dark green. But again, I will also share insights in some of the findings when we visited the facility, what could have attributed to this low performance. This graph just give us an appreciation of the facility performance. These are the run chart for facility performance, which looks at viral load coverage. These are also facility performance. These are the Epworth facility, the 2 Epworth facilities and the Chungwiza facilities. The first one was for the Harare facility. Then in the last 2 months of implementation, we just agreed that we also want to measure the facilities that will be in a position to double the number of samples that they would have collected in April. So we established the baseline performance, that is the samples that were collected in April. Then we wanted to compare it with the samples that were collected in October. But let me highlight this, that we did not look at the clients that were eligible. We're just trying to push the facilities to push the numbers, since there were issues in the lockdown era. So we just wanted to push the numbers in terms of performance. So if you look at Chitungwiza Central Hospital, in August, they didn't collect any sample. Even in the subsequent months, there were some issues around industrial action and so forth. So they were not collecting samples consistently, but in October, they managed to collect something from zero. They were around close to 400 clients that they collected a sample. We also had Epworth Poly. They collected around 500 samples, but in October, they managed to double the number of clients that they collected samples in the month of October. Then moving on to laboratory performance, again, we are looking at viral load rejection rates for samples that have been sent to the lab, as well as the turnaround time. So for this data, I'll present the PSA data, but later on, I will share the NMRL and the BRIDH data. So if you look at rejection rates, the baseline performance for PSI, it was 0.06%. the bars, they shows the number of samples that were rejected in that given month. But looking at the proportions of samples that were rejected across the entire period, PSI was consistent enough to maintain the rejection rates below the set target, which is 1%. But if you look at from August to October, they were at 0% in terms of their rejection rates. Then looking at the overall TAT, so we are looking at the median for the turnaround time for the PSI lab in Chitungwiza. If you look at from January up to May, up to April, the TAT was above the target, which is about 28 days. But from May, they managed to bring down the TAT to below 10 days. So that's the picture in terms of the overall turnaround time for the facilities that PSI is supporting. Maybe just to also mention, we encountered quite a number of challenges. I'm sure we have a presentation on the challenges, best practice, and some recommendation. But let me also mention this, that we also realized that facilities, especially when we are coming to the end of the initiative for the CLI, we also realized that facilities were collecting viral load samples blindly. There were no set targets, be it weekly or monthly. With that, it then affected how we were collecting the samples. We also noticed that there are some serious shortages of consumables. We visited Seke facilities, Chitungwiza. There were reports of shortages of consumables, which also negatively affected the performance in terms of high viral load, because they didn't have the EDTA tubes and so forth that they were supposed to be using. Although we were also pushing for the DPS, but most of the consumables were in short supply. Then lastly, I also wanted to mention there were also issues around the documentation of viral load projects. For the facilities that we visited, we realized that facility teams were putting all their efforts, putting all the hours in terms of implementation, but in terms of documentation of the work that they were doing, it was not being done. Just a few facilities had an updated QI corner or a QI file with updated information or data. So we are, encouraging facility to ensure that whatever work that you are working on, we also want to have somewhere where we can refer to, which shows the work that you are putting into, or the hours that you are working on the initiative. So with that, it brings me to the end of this presentation. Thank you. Over to you, Barbara.
So thank you, Japhet. Just really excellent work there. I want to highlight the site visits. Thank you. I know Fortunate went, Dr. Bobby, I think went, and that's part of LARC, or those site visits. Unfortunately, because of the pandemic, we weren't able to have as many site visits, but important part of actually seeing what's happening. So thank you to that. Japhet, thank you so much for putting together a lot of data, and you didn't get it too early to be able to put it together. So thank you so much. And I think we ought to really, everyone has clapping hands, right? I think we ought to do some clapping hands.
And actually, everybody, if you unmute yourself, then we can clap together.
Oh, okay. We're to be celebrating today, and I think that is the reason. I think the reason to celebrate is that data, because that's what it's all about, right? Getting measurable results, So a real shout
So,
out.
Barbara, if I can
Yes.
chip in with just a second, I was hoping I would just chip in before Javed had put his presentation, had removed his presentation. So one of the most striking things that struck me about the AIM1, if you remember, when we went back to abstract data historically to get baseline data, the facilities had a lot of time to document the results in their green booklet. So I think that's the only thing that I was going to add to Javed's great presentation, that with AIM, with the first AIM, when we collected baseline data, sites had a very long time for them to record the results inside the green booklet, the patient's green booklet. So we really expected that the baseline data would be extremely high because of that bias. So it's important to emphasize that bias anytime we show this data. Then when we started with the first AIM moving forward, facilities only had a 1 month window to record results in the green booklet before we close that window and start collecting for the next month. So that's why it looks as if we started off very high, went down, and then started improving. So it was a process of quality assurance where we're really assured of the data that was coming through. And then that's when we really started experiencing the real improvement in data. So great job, Javed. I felt that was an important point to show for some people that have not been on our webinars, who don't have that that perspective to interpret this. Otherwise, thank you, Javed, for the great effort, and back to you, Barbara.
Thank you so much. So there is a question in the chat box for Epworth. Priska asked, what did Epworth do to double their number of specimens? And again, we know that this is not a perfect measure. It was just a kind of a quick way to say, let's collect more samples. So anybody on from Epworth who can answer the question from Priska, what did you do to double your number? I'm not sure if I see anyone from Epworth. Fortunate, do you see anyone from Epworth who might be able to answer the question?
No, there's no one.
Oh, it was in the Hopi pictures, not on the actual call.
I don't see anyone.
Sorry about that.
I don't see anyone from Epworth. Neither do I see the coach from Epworth. She was saying she's having internet problems. So I don't see anyone from Epworth.
So Dr. Cabo, Japhet, Fortunate, anyone know what they did during the month of October? If you have information or find out information or learn, just put it in the chat box unless you know it at this moment.
Okay.
Japhet, please go ahead.
Yes, I spoke to Charity, one of the team members from Epworth, because I was also curious to know what they did differently, which led to this, huge performance. So they were saying in around August and September, they were, facing, challenges with the EDTA tubes, and okay, let me just say, challenges with the consumables, including the request form. So when they had enough supplies in October, they tried to mop up, the number of the clients that were missed in the subsequent months. That was the response that I got from Charity from Epworth Poly.
Okay.
Over.
Thank you so much. Priska, did that answer your question? Awesome. Okay, very good. All right. Well, exciting to see that data. Here's another photo. If you see yourself or remember where this was taken, type into the chat box. All right, so we did the viral load challenge. Here's another photo. Feel free to type into the chat box if you see yourself. All right, so next on our agenda is to share the results from the LARC survey. So I'm going to stop sharing and we'll let Dr. Katie share the results. We'll both be sharing some of the results from the final survey. Again, thank you to 54 of you who took the time to give us some very important feedback. Dr. Katie, over to you.
Okay, so I'm presenting the quantitative part of the survey. Hang on, let me. So 54 of you completed the survey, so thank you very much. And the first question is, where do you work? So most of the respondents, 40 of you came from the facilities, either clinic or lab. Second question, what is your role in the CLI initiative? Again, most of you, 36 of your participants, 11 coaches filled out the survey, and we have 4 people from program management and oversight. And the remaining 3 people, they say they are one from CKI lab specialist and 2 are viral focal persons. Barbara, can you read the question, because of that view is blocked from me by the Zoom buttons.
Okay, how many of the IHI courses did you complete?
Great, so 33 of you completed more than the 7 mandatory courses, so congratulations. And 17 of you completed between 5 and 7 courses. Okay, could you read the question for me again?
Yes, if you completed the courses, how helpful were they to build your QI knowledge and your skills and your knowledge?
Great, and most of you, 47 of you said it was very helpful, followed by 5 people saying somewhat helpful. Question 6, go ahead, Barbara.
How useful was the LARC workbook?
Okay, so most of you say very useful. Actually, 53 of you, 99% of you say either very useful or somewhat useful. Okay, next.
What QI tools did you find most useful and important? And it was a check all that apply.
Right, so these are the top rated QI tools. Number 1 is PDSA, more than 80%, followed by process mapping, voice of customer, 5S, run chart, learning board is also very popular, followed by the DMAIC, model for improvement, and 5 Whys.
You know, I'm surprised there's no fishbone in there.
I know, I was going to say that. Perhaps you can type into the chat box. Okay, next question, please.
Please rate the overall quality of the in-person sessions. So this would have been back before COVID when we could meet face-to-face. We did the Smart Start and Learning Session 1 back in October of 2019, and then Learning Session 2 was in January of 2020.
Okay, so 26 of you said excellent, and 22 said good. 4 said fair. And we are going to compare this with the virtual sessions. Okay, next one.
Please rate the overall quality of the online webinars and virtual learning sessions. So that's basically everything beginning in March.
Yes. So 13 respondents said excellent, followed by 32 who said good, and 6 people said fair. So compared to the face-to-face sessions, I think they prefer the face-to-face sessions to the virtual sessions. Okay, next, please.
So rate your quality improvement knowledge and skills before LARC versus after LARC.
So before I show the result, let's just review how we define those 4 levels. So novice, meaning you are new to QI, no QI knowledge or experience. And beginner means that you have some implementation experience such as 5S or PDSA, but you are just experienced with the tools, 1 or 2 QI tools. Intermediate level means that you've used the full DMAIC approach. on one or more QI projects. And then advanced level means you are experienced with a DMAIC approach with multiple projects and you have coached others. So if you focus on the green bars, that's the before LARC. Most people are rated themselves as novice or beginner. And a few people rated themselves as intermediate. But then if you look at the gray bars, it shifted toward the right-hand side. So most people say they are now intermediate or advanced level. Go ahead, Q15.
All right. To what extent has your facility achieved the intended outcomes for the viral load scale up?
So 21 said high and 31 said moderate. Oh, one person said low. Okay, next.
So we're asking about the deliverables and the aims that we set. So how realistic or feasible were the required project deliverables, aims, and goals set during this LARC initiative?
So 20 people said they were highly realistic and achievable, and 23 said somewhat realistic and achievable. Okay, go ahead.
And this is the overall quality of support provided by the sites, provided to the sites by the coaches.
So 16 people said they were excellent, 23 said good, 10 said fair, but there were 4 people said poor. Okay, next one.
What is the likelihood that you're going to continue using DMAIC and QI tools and you're going to use what you've learned in the future?
And we were very happy to hear that 42 people, almost 80% of you said highly likely, and 12 people said likely. So we were very happy to see this. Okay, I think that's it.
All right, thanks, Katie. So now I'm going to follow up and we'll be looking at the, I need to, maybe if you're a co-host, if you could just mute.
Yes, I did.
Perfect, thank you. Okay, so this is when you had a chance to write or provide some additional information about those, you rated things according to numbers. That's what Katie shared. I'm going to share the qualitative comments that people made. So what did people say about the IHI courses? So they said it was an eye-opener. They said it was relevant, interesting. They felt like it complemented the lectures. They felt like they added the knowledge piece, the understanding, and then the skills piece with the tools. And what I was pleased to see is a lot of people said it gave them confidence, helped them have confidence, problem solving, empowered them in their work, helped them with their coaching, leadership, and enhanced their QI leadership. And one person said, I am more confident in implementing these projects. The workbook. So as you saw, the majority of people appreciated the workbook. They thought it was well explained, comprehensive. What do you think the most common word was that people wrote about the workbook? You can type into the chat box, most common word. And I cannot see your chat box right now, but anyway, the most common word was reference. They thought it was a great reference. So what was done well? Oh dear. I'm not sure how to get that off the screen at this moment, but our online virtual sessions, what did we think was done well with the online virtual sessions? So, you know, the presentations, people really love the presentations. They love the presentations by the participants, the facilities. They liked guest speakers, the facilitators from other country. Loved hearing about best practices and idea sharing. They like Zoom education, learning how to interact in a Zoom world, the breakout rooms, of course, polls, icebreakers, energizers. People like the music at the beginning. And then some people liked introduction and attendance check-in. And then if we focus on the educational content of the presentation, well done, well structured, well prepared, well delivered. They liked that we started on time. The engagement with the audience through the chat box, they felt encouraged, timely. The feedback provided, annotated screenshots of the feedback, the assignments, the timetables, and fulfilled session objectives. So those were the things that people felt were done well about the online virtual sessions. Now, there were some recommendations for improvement, and we love to hear that. We are an improvement organization. The biggest one was time management, ending on time. So, message well heard. We will end on time today. We have 2 hours today, but we will definitely end on time. So, time management. The duration. Some people thought it should be shorter, and some people thought there should be more time for the lessons or more time for questions. They felt like it was pressurized. There were some concerns about the day and the date, a suitable time, flexible times, different day, not during work times, and reduce the frequency. We heard loud and clear that people were concerned because their patient care had been interfered with. They suggested perhaps we could do some things outside of work. And of course not, with the virtual world, there was nothing physical or tangible. There was no lunch. This maybe comes later, but they felt like independent coaches who could help focus on coaching. They wanted more active participation of all the teams, more group participation to encourage attendance, education for people on how to do presentations, more energizers, and improve the process for data and airtime. Again, we appreciate this kind of feedback, and it will help us discuss this as we go forward and look for potential solutions. There might not be solutions for everything. There might not be a perfect time for everyone, but definitely important feedback. So thank you for sharing that. Did we achieve the outcomes? The people who said yes, and you saw some people said yes, some people said they did, and some people said not. But some people said there were great improvement in communication between labs and clinics. And that is a key thing that we were focusing on in this lab clinic interface. So I was happy to hear that, and multiple people echoed that. And then the metrics, people said that the metrics did improve. Some people said no, they did not achieve the outcomes because of COVID and the things that we all know and are saddened by, the industrial action, the closure of facilities, stockouts, staff movements. And then some people said that they had a moderate improvement. They said it was gradual improvement. They were still implementing, still needed support. This person said, we have managed to change a lot of things in our viral load fields, especially documentation of results and management of high viral load. And then another person said many things have changed. So good that, there's been some movement. So were the project deliverables feasible? Most people said yes, that they were things that were being done at your facility level anyway. Those are things you're doing. That is your work. Some people said no because the pressure of work, the implementation period was too short, or they were competing events. Someone says the deliverables are highly realistic or not for the lost opportunities due to COVID-19, delay in service kits and consumables, and restrictions. So the overall quality of the coaching, and as you saw, most people were very, very pleased with the coaching. So comments like very good, supportive, proactive, available, always there. Kudos to the coaches. And I like this comment. They said, lifted us up when we were stuck. So that's what coaches are supposed to do. There were a smaller number of people who said that there have some concerns around the coaching. So I think this is something, you know, we'll want to take under advisement as we move forward. They said there were just even, you know, some of the people who said, I am a coach. They said, I have too many competing events, programs, duties affected by COVID. And there were some comments that they were not available, no tangible support, and not forthcoming. And then continue using DMAIC. Will you continue? And this person said, since we have learned a lot and have started implementation and it's working, we're going to keep on going. So great to hear that. And as you saw, the majority of people said that they would continue using this. One cautionary tale, though, it depends on staff coverage and support from partners, is what one person said. So challenges. Some of these I feel like are outside the control of all of us. The COVID, of course, the poor network connectivity and personnel and staff shortages, the incapacitation. But many of them I think are potentially within our control. And people mentioned time and competing priorities, suboptimal commitment, poor participation of all the cutters, the pressure of doing LARC and work simultaneously, that there didn't have data, the facility ownership of the project. Someone said needs a full-time team, no hands-on practicals at facility, and that the clinics are very busy. And those are, of course, significant challenges. Overall success. How did we do overall success? Again, improvement between lab and clinic. That came out loud and clear. The improved metrics. The QI tool use improved. Teamwork, awesome. Peer learning. Many people mentioned they were more organized at their facilities. And I thought this was a nice quote. It has allowed us to sit down and design strategies before implementation, which saves time and resources. So those were the overall successes. And a couple more that I enjoyed. Number one was it works. So always glad to hear that. And then the next one, there was a marked improvement seen in management of patients on ART, especially viral load collection. So when we started this at the very beginning, we talked about the benefits to the patients, the clients, and the benefits to us as healthcare workers. That this, using quality improvement to do the way we do our work, the work we already are doing, is a benefit to us. But was happy to hear that someone felt that it's also a benefit to the patient. So appreciated those comments. Here's another photo. If you see yourself, type into the chat box, and if you recall where it was, bonus points. All right, best practices. So I'm going to pause here for a quick minute and look at the chat box and see if there are any questions. Maybe Katie, if you could see that. Okay, so someone says Rainbow Towers in Harare, learning session 2, awesome. There's some folks here. Japhet, there's a question for Japhet. About, would you mind also putting a graph of site targets of viral load collection samples versus what was actually collected? So Japhet may want to speak to that. And I think he spoke to that briefly in saying that some of the sites did not have targets, and perhaps that would be something that could be added. Again, the monthly sample collection, it's not as meaningful as something that has a denominator, but it was kind of an opportunity just to kind of encourage everyone to collect more. Japhet, did you have anything to add on that question?
Yeah, I think you have explained or responded it well. Yeah, most of the facility didn't have set targets, so maybe we might need to assist the facility in setting those targets. Then we can have such a graph. But as of now, most of these facilities do not have these targets in place.
Okay. A question, any reason why the fishbone was unpopular? I'm not sure it was unpopular, just didn't make the top 9. Dr. Cabo, you have a question and I'm not sure what that was referring to. If you want to open your mic.
No, nothing new. So my connection went out, so I can't see what I typed earlier, but apologies for that.
It says
So
educational question mark, so.
No, typo, apologies.
Okay. Lots of people are saying Rainbow Towers. Yes, that was our second learning session. And Katie wants a LARC song and dance. All right, did I miss anyone's question?
Oh, I just remembered, Barbara. So that was, you had asked what descriptive word was most likely used by people when they were referring to the guide. So I thought they said educational.
Oh, thanks for the response. Most people said that reference was the most popular word, but I appreciate the response there. Always like to be interactive. All right, so I think we're caught up. If there are any other questions now, we can take them, or we can take a quick look at some best practices. So how are we doing with the time?
So Barbara,
Yes.
maybe I can comment on Dr. Junior's question that any reason why the fishbone was unpopular. This is my guess, because we didn't really use the word fishbone in the survey in that question. We used the name cause and effect diagram.
There you go. That was a good thought.
Oh, okay. Thank you.
It has 3 names, Ishikawa, fishbone, and cause and effect. So.
Okay.
All right, so take a deep breath. We're going to share some best practices. If your best practice is not in the presentation today, that might be because I haven't received your presentation. And a comment, some of the things as I was reading through the comments, I noticed that people wanted to hear more from participants, and that would be fabulous. We enjoyed that when we got the opportunity to do that. But if we don't have presentations from folks, we cannot share them. So really presentations were key to you communicating to us, what have I done? And then we could grab your presentation. If we got it by Monday night or early Tuesday morning, then we could reach out to you, say, yes, we want you to present. So we will share some of the best practices that we have now. We'll collate them into a final report, and of course you all can receive that. All right, here's another picture. Anyone see themselves? I do. All right, so from the clinics, let's start with AIM-3. That's the one that we've been working on most recently. That was the viral load coverage. So we gave you options about thinking of different areas that you could work in. And really the people chose more in 3 different areas. The appointment system. So explaining to the person when they were initially initiated, I think that's of course key. Putting the appointment in the appointment diary in the OPD book, and that's the one the patient carries if I'm on the correct track here. And I think that is key to patient ownership. So I thought that was a really important one. You know, eventually we may be sending patients their results via SMS or telling them to go to the clinic, however that may come out, but patients must own this process. So putting it in their OPD book, I think, was a great step toward that. And then just tracking down missed appointments. So those were the things that people tested. Improved clinic access. So this is process redesign. This is taking your old process of how people are accessing, coming into your clinic, moving through your clinic, who's doing what, that whole process map. This is redoing that. So Quadzana used a sticker system. They had stationed a full-time PC for viral load sample collection. So kind of reassigning people, and then they would collect DBS samples for clients who missed the plasma collection cutoff time. So if you have the patient there, they were drawing the sample, but collecting it with the DBS. Hopefully, again, thinking about their client flow, they screened everyone at the entry point. Every OI patient at the entry point got screened or checked for viral load eligibility. And there was a PC assigned to do that work. And then they documented the viral load due date. Again, I think that's in that OPD book. And then Hatcliffe, they synchronized their drug pickup with viral load sample collection. These are all things that we know will work well. Perry also put the sample collection in the OPD card. Again, patient ownership, and then they put it in their appointment system. Realigning client flow, so screening for viral load eligibility. So I think you'll see a theme there. Several people are looking to screen clients, anyone who comes to the clinic, and then making an SOP, which of course is key. Mbari, and I think they spent like 4 days doing this. Initially, they went through their cohort and identified clients due for viral load. And they spent a lot of time really looking through those cohorts. And just whenever a client would come, they would catch them up. They would document the contact details. So important to have a way to reach out to the client, right? And then that way they were able to send SMS reminders. And they also improved their viral load sample collection from pregnant women as they came to ANC by attaching a cotter to that clinic on particular days. Again, anything you can do to think about catching the client while they're there is, I think, a very important best practice. And this patient client activation, I know that daily health education and engaging expert clients is something that has been done many times. This team, they outline ways that the clients can access their health information and medical care. Again, I think that's super important in letting clients be owners of their care. And of course, they talk to them about the importance of viral load. Another option that the team did, and actually our teams in Mozambique did this as well, and I think it's a very important factor, is to educate the service provider. They actually had a quiz for the service provider, but many times there are things that we think we automatically understand, like when is the viral load redrawn after the patient has a high viral load, but we may not all be on the same page. So I think re-educating keeping up to date with the service providers was also a best practice that I saw. Best practices that we saw in some of the presentations, go ahead and put in what changes you made on the run chart so we can be able to see the effect of each of the changes. And I'm going to pause here just for a second. Any best practices that you all picked up on your site visit, Dr. Cabo or Fortunate, Japheth, anything you want to add in here around best practices that you may have seen that maybe we don't have reported yet in the
Dr. Cabo just type some one
Thank
best
you, Barbara.
practice
I
he
just
saw.
typed something on the chat box. So essentially, the office facilities that we supported, they put something on the client health sticker. Again, it's in line with the theme around patient or client empowerment. So what they do is they put a sticker on the client health card with a date of the last viral load. So it's a way to keep in touch with each time you're seeing a client, you're just searching for the sticker to see whether they are actually eligible for a viral load or not. So I thought that was great best practice, and it helps facilities to easily identify people that were eligible for another viral load test. Maybe Fijani and the team can tell us a bit more around how they implemented that, how easy or difficult it was. Fijani and your team, the anniversary stickers on the client health cards. Any comments on that?
Okay, so what we had, we have a sticker system. Well, there are two sticker systems that we have. The initial one was the reminder sticker, which was the blue sticker that was placed on the green book to remind the healthcare worker to attend to a client with the blue sticker. And then the second one was a reminder for the client that was placed in the client booklet when they visit, giving the next date for viral load. So it assisted to remind both the nurse and the client in any event that one or the other was not paying attention. The sticker reminder would assist with that.
Johnny, who did the sticker system? Which cadre or at which point in the process was the sticker affixed?
Okay. In our attempts to scale up our sample collection, the blue sticker, which was the reminder sticker for the facility staff, either the nurse or the primary counselor was the one who attached the sticker to the green book to highlight that in any event that a healthcare worker attends to a client with a blue sticker, they will look out or offer the service. And then the reminder sticker for the client, it was conducted by the nurse in the consultation room. So when the nurse is either giving medication, she will now see the next whether the client is up for a viral load visit. So that's when he or she would engage the client and remind them that I'm putting the sticker in your book with the date for your next viral load visit. So pay attention. So as the client is leaving, the nurse would remind them for their pill pickup / next viral load. So we would tie in the sample collection date with their next pill pickup.
Thank you so much, Fizjani. Now I see a question from Chiedza. I want to hear more on SMS reminder for viral load. How were facilities doing it? So if someone can speak up on those of you who did SMS reminders for viral load is that coming from the clinics? I'm pretty sure those were coming from the clinics based on appointments or missed appointments. Anyone can speak to that? Maybe Jackie? Okay, while you're thinking about that, we'll keep going, but if someone can respond about how they're sending SMS reminders for viral load. Again, I think it's an appointment reminder if you missed your appointment. Anyone can comment on that? Fajani is showing us something.
So this is the reminder sticker for the patient. It shows it says treatment now, know your viral load, your next viral load appointment is on, and then the date is put in there, then the sticker is placed in the client's booklet.
I like
So
that.
there's reminders for the healthcare workers, there's reminders and cues for the healthcare workers, but this one is specifically targeting the client themselves, a reminder for the clients to also remind the healthcare worker if they are due for a viral load. Yeah.
Wow, that's fabulous. Does everyone have those stickers? Do other sites have those stickers?
As far as I know, it's only 5 off-it funded facilities, the Chitungwiza ones, but I may be wrong. I stand guided.
Okay. Awesome. Anyone?
Bulawayo has as well. It's off it. So I know Bulawayo and Chitungwiza are the ones who have. I'm not sure about the IT supported site because this was from Office.
Anyone can answer Chiazza's question about SMS reminders for viral load? I know several people are doing that. If you type into the chat box, and we'll pick you up in a minute. All right, so let's go to aim 1. So documentation of results in the Green Book. Again, these were the best practices that you all have sent to me, but I'd love to hear more. So basically, document and file it the day it comes. That seemed to be what I saw from a lot of different sites reported that. And then one of the sites said they involved some lay cutters in filing and entering the results under supervision of the DEC. This, I think, is a way to catch up if you, all 4 PCs went to the filing rooms on Fridays to document. And so this would be the catch-up option if you weren't able to do it every day as you initially planned. And then this viral load for focal person. So I think I heard that probably in everyone's presentation about a viral load focal person. If you have initiated a viral load focal person at your site, type quickly into the chat. I think most of you have. So I think that's just a key. We've learned that from other countries, having a viral load focal person who is responsible for keeping track of that whole system. So if you have those, type into the chat box if you've assigned a viral load focal person at your site. The aim 2 was care according to guidelines. This was the one that probably, the aim that probably got cut short the most because the time to work on it was really during the COVID lockdown initially. But I did receive some best practices. So it's basically keeping your eye on the ball, tracking and tracing all clients who have a high viral load. Anybody who misses an appointment, track them down. And having this viral load focal person. I've got some details on some of the high viral load management, kind of standard care, but the one that I thought was really important is that on EAC3, the client is given a 2-month supply so as to come back 12 weeks after the EAC. So I know when we ask, sometimes people say, well, is it like 4 months or 3 months, or when does that actually come back? But spelled out very nicely in this. Then pulling out the green files for clients who are having a high viral load and monitoring them separately so you can keep on top of them. Calling clients as reminders on the day before the appointment. And then this sticker system, red, to flag out clients with high viral load. So moving these people out, having a person responsible for monitoring them, and then just following the algorithm. I saw some best practices around 5S. I saw a desk and carts, and here we are at another session. So that is, I'm going to bring some lab best practices in. And aim 1 was to reduce the turnaround time. This is from PSI Lab, and I think, I know also BRIDH Lab did this as well. We'll talk about that in a minute, but they re-engineered their workflow. This is not like incremental change. This is like explosion of what you're doing and starting all over, okay? So this was a huge process redesign. So they worked on their transmittal sheets. They reassigned their workstations. They went to shift work. You know, people are working around the clock. They did the result notification and emailing, and they created SOPs. And our labs are, again, fabulous at creating SOPs. So they shared them with me. PSI Lab has a QI dashboard, which I cannot recommend enough to every facility. And they worked on their confidentiality encryption and lab clinic interface. That's what we're all about. And they did their WhatsApp clinic lab interface. So another way to just keep that communication flowing. Here's their dashboard. I feel like that was a best practice. BRIDH also just blew up the current system and restarted with a whole new process of increasing the testing hours, basically going to shifts, making sure your equipment is utilized around the clock. They increased data encoders. They used other backup labs if they had backlogs. And this one I thought is super important, and everyone on this call could implement it. Set targets. So they set their daily targets for testing and monitoring, and they reviewed them weekly. You won't go anywhere unless you have a target and keep your eye on it. They did, of course, the SMS test with Mbari and did a lot of lab clinic interface there. NMRL Lab, their practice is more to the remote hubs. And so they were able to go and work with some of their remote hubs and reduce that post-analytic turnaround time. That was kind of like a big unknown. We didn't know what was happening in the time between the test is done and the results get or don't get to the facility. So using SMS and email platforms, and realizing that if you have an email platform, maybe the site doesn't even have email, doesn't have internet access. So really some important work done there to help the hubs. They looked at rejection rates. In MRL, in the lab clinic interface category, they collaborated with provincial laboratory scientists to intervene with sites that had high rejection rates. So spend your energy on the sites that really do have high rejection rates. PSI Lab, they went around and did training on sample collection. They created a specimen rejection log, and they communicated when the specimen was rejected. And I have for you, and we're doing well with time, I have for you just a bonus this morning, some tips for sustaining your improvement. And so give me another 5 minutes and here we go. So tips for sustaining your hard-won improvements. Number 1 is standardization. Standardization, standardization, standardization. How many times can we preach that? Accountability. Number 3, a visual management system. I think we talked in the very beginning about having a board with your QI corner or your data on it. Daily communication huddles, and we're going to talk about that specific one, and then having a problem-solving technique. You have it, DMAIC. So standard work, cannot stress enough. If you found something that works well, you document it, you standardize it, and then everybody does it that same way. The boards, you must have a board, and then huddles. And that's what I want to give you an extra tip on this morning. This is a bonus. Patient safety huddles. There's a toolkit that you can get from your IHI. Now, remember, your IHI will expire in December. So if there's anything you want to go in there and get, you need to download it before then. But they have a toolkit on huddles. And I'm going to show you a quick video on a huddle. It's of a primary care clinic in the state of Washington. May not completely apply to you, but what I want you to notice, key in on these factors. How long does it take? What's the total time for the huddle? What metrics are they tracking? How did they choose their metrics? And where or how did they meet for their huddle? So 4 things. Watch the video and we're going to come back and ask. I'm going to stop it as soon as I start it and make sure everyone can hear.
Good morning, if we could.
Yes.
Right. You can hear. Awesome. So here we go.
Everyone here for the daily huddle.
Good morning, everyone. Today is Wednesday. We have Dr. Way, Dr. Salazar, Paige McClincy, and Dr. Isle in the office today with Renee, Kay, Christy, and Susan.
We talk about how we did yesterday, measurements like visits and how many add-on patients we had and how many were in the walk-in and how long it took to answer the phones. And we talk also about what's happening today. Which doctors are working with which staff, who has availability to add patients, any meetings or anything else going on for the day.
Our nurses today are Amy and Kim. We have Dr. Laughlin in the walk-in clinic with Sharon in the morning and Marin as our nurse. Today, we're looking at a pretty busy day, full day already. We're starting today at 48% with Dr. Isle, 100% with Dr. Salazar, 96% with Dr. Way, 100% with Paige McClincy, and it looks like we had a busy day yesterday, 35 patients in the walk-in clinic and a total of 128 patients in the building. We added on 15 total patients yesterday.
For reception, it's very helpful. I use it all day long. Knowing which doctors are here is very helpful, knowing who's working with them, which MAs, which nurses are here. Because we switch around a lot here, it's helpful to know where everyone's at for the day. It's also very helpful to know who's in the walk-in and who's working there, and all that information is there for you. I also use the percentage for booking. It tells you how many patients are already booked on the doctor's schedule and where you have room to work people in if you need to.
Yesterday, we had 233 calls with a 5.58% abandonment rate, still well below our 10% abandonment rate goal. And we had a 27-second average speed to answer yesterday underneath our 45-second goal.
We chose ourselves what things we wanted to measure regularly, and they're linked to what we want to be doing as a satellite, as a group. We've seen improvements
this morning
that seem related to this process in areas that had been pretty intractable for a long time.
An ACT team meeting today from 1 to 2, and tomorrow, which is Thursday, they will be completing our installation of Outlook 2007, and Ellen Baker will be here tomorrow morning to explain to people how to use it. That's all. Any other announcements today? No. Everyone afraid to talk. All right. Have a good day.
Okay. So who picked up on the total time for huddle? You can open your mic. You can type into the chat box. What was the total time for their huddle? So Dr. Masvangwa says 3 minutes. Dr. Katie says 8 minutes. Priska says 8. Okay. So did you see the little time clock running? You could tell how much time. I got 5, but you know. Oh, good. Someone else got 5. I thought they started at 7:50 and stopped at 7:55. But anyway, the point is very short amount of time. What metrics were they tracking? Looking at my chat box. Oh, someone else got 5. Awesome. Lenovo tablet got 5. Response time to calls. Perfect. What else were they tracking? Clients coming through, exactly. Number of people who came through, number of clients attended to, number of patients from yesterday, meetings, perfect. I think they tracked call abandonment rates, time to answer the phone, how many walk-ins they had, who was available, the daily allocation. Yes, yes, all good things. So that's what they were tracking. And how did they choose those metrics? How did they choose those metrics? What they were tracking? I think the physician in the white coat gave some hint. They agreed. Yes, they did. They agreed. And they decided. They said, we track what we want to be doing. We track metrics based on what we want to be doing. Priska, yes, perfect. NMRL lab, work together. Awesome. And then the last but not least question is, where or how did they meet? Some important little pickups there. Where or how did they meet? Hallway in the office, okay. Say more. There's something more that I want you to pick up on. So good teamwork for sure. They met by the board. Katie, you win. They met by the board. The board had daily live data on it that they're tracking. What else did you notice about how they were meeting? Oh, Katie, stop answering all the questions. Someone else needs a chance. You got it, Katie. They were standing up because it's a very short meeting. If you sit down, you tend to want to stay longer, right? It keeps it. So no need for a boardroom. Exactly. You stand wherever you are, you stand. It's 5 minutes, you move. Very brief and to the point. And this tool that from IHI helps you determine what you want to be in your daily huddle. And you basically create a script. We're going to talk about these 5 things and we're going to talk about them every day. If there's, so really a helpful tool there. So that's my bonus tip for you today. Here's some more people. Oh, this one is taken in a different spot. Anyone know where this one was taken? All right, so I'm going to stop sharing now. I'm going to turn it over to Fortunate, who's going to share our dashboard. This is what we're measuring. This is what we're interested in. This is what we're tracking. So Fortunate, over to you.
Thank you, Barbara. Today, I'm not really sharing a dashboard because there isn't much change from last time. So I just have a slide. Can you see my slide?
Not yet.
Okay, let me see. Can you see it now? Can you see it now?
Yes, Fortunate, we see it now.
Okay. Yes. So I'm just giving you an update because the scorecard didn't change much, so I didn't put it up. So I just have a narrative there. Looking at the IHI courses, there's been no change on the IHI dashboard, where we still have information from end of October, because we only get an updated information end of the month. So by end of October, we had 250 tickets in use. and 250 tickets remaining. I know some people have managed to do some more IHI courses, of which I don't have a record because the dashboard has not been updated. And also, I know we've had some people who've had challenges using the new IHI dashboard, and Japhet has tried to help some, but we still have challenges. So some people have not managed to go on with their courses because of the change on the IHI dashboard. But we are looking into this, and hopefully we are going to be able to rectify this. And then, unless Japhet, do you have anything else to add on the IHI courses there on the dashboard, which is giving us problems?
Yeah, I think we need to take it up with the IHI team because it's not giving us an option to enter the passcode. So it's requesting us to pay for the courses. Whereas with the previous one, once you click start course, it will request you to enter the passcode. So we have tried using the instructions that are on the website, but we are failing to, gain access to the courses. So I think we need to take it up with the IHI team.
Thank you, Japhet. Maybe since Priska is also on this call, maybe she'll also assist us in looking into this and how we can go over this. And then looking at the webinar attendance. On the webinars, the last webinar, we had 55 people attended on the 21st of October. Then 2 weeks ago, the last webinar on the 5th of November, we had 61 attendees. And this increase we noted, it was from facilities like Heathcliff, Hopley, and St. Mary's, where previously on the 21st of October, there was one person who had attended, but on the 5th, we had 3 and 4 people attending. So this is my update on the dashboard. Thank you.
Thank you, Fortunate. There's a little more in the chat box about, I think, huddles. So there's a point from Josephine saying rapid response. Priska says no need for a boardroom. Nora says very brief and to the point. I bet Nora has a huddle every day in her lab, if you want to speak on that, Nora. St. Mary's is where the picture was taken. Yes. I like to describe huddles. It's from Dr. Cabo. Dr. Cabo, you want to open up and make your comments?
I thoroughly enjoyed this video, although I was distracted by a phone call, Barbara. It's explaining a concept that I always struggle with when I get to a facility. You see facilities that lasted a QI meeting 2 months ago, and they are waiting for this big platform when everybody is free, where they can then discuss QI. And those moments are hardly ever there. People always have stuff to do, clinics are busy. So rather than waiting for a time when everybody is free and you sit for 2 hours and discuss broad QI concepts, it's easier to meet for like 5 minutes at any given time to discuss a small aspect of QI and have that continuity on a day-to-day basis. So I often like to describe it as feeding a child with malnutrition. So small, frequent doses rather than this one huge meal that takes 1 hour with 3 different courses. So small, frequent doses, 5-minute meetings on a day-to-day basis are better than a 1 hour meeting once a month. Yeah, so thank you for that. It was quite insightful.
Beautifully said, beautifully said. Let's see, rather than waiting for a big meeting. Okay, we got that. Then with Huddle, everyone keeps track of what is happening. That's from Patience. Thank you, Patience. Nora, did you want to say something about how you do huddles in the lab?
Hi, Barbara. Yes, huddles are done all the time in the lab. Usually when people are working, you don't have time to then ask everyone to get out of their PPE and sit down for a meeting. But yeah, so huddles work well.
Do you usually do them at the beginning of your shift?
beginning of shift, sometimes when shifts are changing, when you have another group leaving and another one just coming in, that would be a good time to have a huddle also, so that you have both groups present.
Mm-hmm. Great points. Okay, thank you. Anyone else? Feel free to open your mic if you have experience with a huddle. Love to hear that. All right. So we go back to this to move to the, there's a picture. There's a picture. If you see yourself, type in. All right, so the moment we've all been waiting for, drum roll, the certificates of participation and awards, and I will turn the time over to Fortunate.
All right, just a few minutes, just a minute. Okay. All right, thank you, Bob. I think this is the time everyone has been waiting for. And then our, and this, we did it overnight. We only discussed and finalized this yesterday around 5 when we had our planning meeting. So I've just received the certificates now. So I'll just flash them. So I couldn't share them with Dr. Cabo because I've just received them now when we're having our meeting. But I'll just flash them, and then Dr. Cabo will do the honor of giving them out. So I'll flash them from this end. Okay.
So, Matron, today we have the pleasure of my boss's company. So, Dr. Mpangori is in. I'll ask her to assist on that front. Dr. Mpangori,
thank you.
Apologies for putting you on the spotlight.
Thank you. So, the first, Dr. Mpangori, thank you for accepting to do this at such a short notice. So.
Thank you, Fortunate, but I'm not sure what I'm supposed to do.
Okay, so
I'm here to help Dr. Mpangori, don't worry.
Okay, so Dr. Mpangori, we have 4 categories. So the first certificates, I'm just flashing certificates of participation. These are awarded to all the facilities, all the 15 facilities we're working with in this cohort. And then after that, we also have 3 categories which we're going to look at. We are going to have certificate of excellence awarded to the facility for data submission of all the 3 metrics. So we have 3 facilities are getting awards for that. And then we also have another category where we are giving certificates attaining the highest completion rate for the 7 mandatory IHI courses. We also have 3 facilities getting certificates for that. And then the last category is for the greatest webinar attendance by a team. So we also have 3 facilities getting certificates for that. Is it okay now, Dr. Mpangori?
Yes, I'm sure Cabo will assist. Thank you.
Okay. Yeah, so I don't know if you can see my screen. So the first batch of certificates which I'm flashing are certificates of participation. So maybe you can just read through them. So what I've done is to write the facility name, including the team members' names who are there. So you will note that these certificates have not been signed. So I'll be bringing them to you, Dr. Mpangori, for signing. So because they were delayed, I couldn't bring them over to you for signing. So I'll do that either tomorrow or on Friday. We can talk later. So I don't know if everyone can see my screen.
Yes, we can see your screen, Matron. So for
Okay,
I don't know whether we want to go through. Oh yeah, I think we can quickly flash the certificates of participation just to see if there are no typos in people's names. But we can quickly go through those. But we can focus on the certificates of excellence.
Okay.
Does that work,
So-
Matron? So we'll flash
Okay.
for each clinic. We'll ask the participants to confirm that the spellings of the names are in order, 30 seconds per certificate, and then we'll spend a bit more time under the certificates of excellence.
Okay, thank you. So
everyone, if your clinic is on, please try and look and see if the spellings are in line with what is in your ID, in case you need to use the certificate for job hunting. But please don't do that.
okay.
So teamwork with Polly.
I think
I
we'll
hope somebody
pass.
is on standby.
I think
to
there's
check
no
the
one from
spellings.
Airport. I think there's no one
So
from
we'll
Airport,
confirm
so
with
I
them
can
before
move
we
on.
print this one. I think we can quickly move on to the next one.
Okay.
If
I didn't
there's
see
anyone from Overspill,
again. I didn't
so
see
if you
anyone from
spot a
Overspill.
typo, if you spot
Okay.
a typo, please type on the chat box so that we can also adjust the spellings. So Budiriro Polly, please scan through the certificate.
I didn't see anyone from Budiriro, I think, again, so I'll pass.
The good news from Budiriro is they've since reopened. Confirm, Metron.
Yes, Jackie said so.
Okay, thank you. So Team Mare Poli, please check. The coach, I think we got an update from Nicholas saying the coach from Mare Poli is actually hosting a team from CDC. So she's not on the call, but if there's anybody from Mare Poli, please just check through. I think Karen doesn't have a surname there. We'll need Karen's surname.
Okay, no, I think Karen, I think there was a typo there. This is the same name, it's Karen Maburukwa. But I think
I
there's
see.
so I'll
I see.
correct that. Yes.
Thank you, Metron. We can move on to the next one.
Any corrections there?
From Guatanapoli. Okay, thank you. Heathcliff Polly. If there are members on site, please just scan through and then type on the chat box if there are any typos that you have spotted. Mbare confirmed that everything is in order. We just need to remove the comma between Karen and Maburugwa. Heathcliff Polly, I think everything is in order. Hopefully, is anybody from Hopefully on the call?
Yes, Carol Moyo.
Yes, Carol, please confirm this, that the spellings are all in order.
No, everything is correct there. Thank you.
Thank you, Carol. Patty. Is Fiona on the call? She's usually on the call on behalf of Patty. I know Nicholas is on the call. I saw a few chats from him. Nicholas, are those your team's details?
Yes, that's the full team. Yes, that's the full team, Dr. Kawo. I'm sure maybe Fiona, you can check the spellings as well.
Thank you, Nicholas.
They are okay for Patty.
Thank you, Fiona. Thank you. PRIDH.
They are not on the call, so I think we can pass.
Okay.
They have an audit today.
Okay. Chitungwiza Central Hospital.
Hello.
Tijani, I know you're on the call.
Yes, everything seems in order. Team
except for the comma after Catherine.
The comma between Catherine and Apasua.
And Apasua.
Yeah.
Thank you, Metron. NMRL.
It's Jana Kireni. It's Jana Kireni.
Okay.
Is Nora not part of the NMRL team, or she's part of the faculty?
She's part of the faculty, so I don't know if she would want me to add her name there.
Machinery there. I think she has been known to operate the machinery there every once in a while. I'll get in touch with Lucia and confirm with you.
I think Nora is on the call. She was on the call. Maybe she can confirm. If she wants me to put her name there, I can do that.
No worries,
I think you've
Fortunate.
run a few runs.
Should I?
Yes, I have, but I can appear on the faculty. It's fine.
Okay, all right.
Thank you, Nora.
Unfortunately, there's nothing for the faculty.
That's still okay.
Just get a thank you at
all
the
right.
end.
Okay, thank you, Nora.
Samuel and Tim. The Mubaiwa, I think we need to lose that comma.
Okay.
Samuel, last time I was there, I know you had a biggish team. Are these all the names, or you want to add a few more?
Rufaro is Rufaro Magadu, not Magudu.
Magadu.
What?
Magadu. GA.
So that U needs to be an A.
Yes.
Okay, Magadu.
Yes.
I always get this wrong, and I did confirm with you in the morning.
Yeah, sure.
All right, noted.
Second note, clinic. Anybody from second note?
I think second we had no bet was on the call. They were all there. I'm sure they are okay.
Yes, we are there. Second note.
So the names, are they okay?
No.
Yeah.
On second note, on no bet, it's Robert.
Or Robert.
It's Robert Nobet Jaka.
Yeah, okay, but we want to put one name because if there are too many, the certificates also. So which one should I put? The no bet, you don't want the no bet appearing.
All right, it's fine. No bet, but then without an error between O and B.
Oh, okay.
Okay, thank you for the correction. How about the rest of the team?
On Chivayo, there's no H, it's Chivayo.
Okay.
Okay.
Noted.
Yes.
Noted.
I think that's all.
Okay, thank you.
Okay, thank you.
Team Zengeza. I know Team Zengeza lost a colleague who went into the private sector. Is that why there are 3 instead of 4?
Yes.
Yes. I saw Mr. Karamba. I think he should also, if he can confirm, and then the spelling book fine.
Is what?
The
Is Annie suggesting we add some other name?
No.
You said
Mr. Karamba is on the call. I was saying he can also confirm if the spelling
okay.
is fine.
I think I've noted there's no space between Fijani and Newati. I think I'll correct that.
I was wondering why I didn't know this coach, Matron.
Okay. So can I move on?
Yes, please go ahead.
Then.
And then there's St. Mary's. Team St. Mary's, please confirm the details are correct.
It's correct. Hi, everyone.
Thank you. I think that's the last one.
Team St. Mary's, that's the last one, Matron. I think we can move on to the other certificates of excellence.
Okay, let me do that. Okay, now we're on the certificate.
I haven't seen a certificate of excellence for Barbara and Katie.
Oh, maybe they're coming. Let's wait and see. So now on the certificate of excellence, those are the certificate of excellence. Maybe you can go ahead now or Dr. Chiesa can read them through and award them. I'm not sure how we're going to do it.
No, I can do the reading and then ask Dr. Chiesa to hand over in codes. So Dr. Mpanguri, I'm handing over the team from PSI Lab. I think we want to acknowledge their efforts in terms of completing our 7 mandatory IHI courses. So the team from PSI Lab, the whole team did manage to complete all the 7 mandatory courses. I think everybody on the call needs to give them some applause to acknowledge the great job that they did. So good job to you, to Samuel and your team. Keep this up. So Samuel and Tim will come to take pictures with you sometime.
Well done, PSI.
I think when we take the certificates to them, we can have pictures then.
Yes. Team Zengeza Clinic, I think, is another clinic that stood out in terms of completing the 7 mandatory courses. It's easy when I'm just reading, but trust me, completing those mandatory courses needs commitment in terms of time and commitment in terms of completing the courses. So to the in charge from Zengeza and the coach, thank you for pushing your team. Congratulations, Zengeza. I think we can clap hands for Team Zengeza.
Well done, Zengeza Clinic.
From Harare this time, Heathcliff Clinic is also another clinic with a notable achievement. The whole team also managed to not only start, but also complete the 7 mandatory IHI courses. So congratulations to you, Team Heathcliff, to you and your coach.
Well done, Heathcliff Clinic.
Data submission. Now to an area where a lot of facilities suffered. These are facilities that I want to especially mention and acknowledge their commitment from. So Jafet has shared the data. It's not a complete story because some of the facilities here did not manage to submit all of their data on a month-to-month basis on the 3 matrix. So Kwazana Poly, you stood out by being one of the few facilities that managed to submit all of the data on time. So Team Kwazana Poly and your coach, congratulations to you.
Well done, Kwazana Poly.
Team Overspill Clinic, again, you stood out, a very busy clinic with almost 8,000 clients on ART, but over and above, just meeting as a QI team and also going through all the processes that all the sites here went through. You also successfully managed to submit data from all the 3 matrix to Javed. So congratulations to you and your team. Is Sonia on the call? Congratulations, everybody from Overspill.
Well done, Overspill Clinic.
Okay, we've done Kwazana. We went down, we've done Kwazana.
Okay.
We've done Overspill. Okay. Now PSI Lab, again, PSI Lab is a great example of teamwork at play. I've had the pleasure of visiting them for an afternoon. I was really impressed with how I interacted with the whole team. It wasn't just the coach who was responding to our questions. You could see the team dynamics at play. So congratulations to the coach, Samuel, and congratulations to the whole team on successfully submitting our data across all the 3 matrix. So congratulations, PSI Lab. Keep it up.
Well done, PSI Lab.
PSI Lab again has made a notable achievement in terms of their webinar participation. So as ministry, we went out of our way writing concept notes and letters requesting for facility teams to receive airtime so they could not only complete the IHI courses, but also use these to attend all our webinar series that our consultants went through a lot of work preparing for. So PSI Lab, again, we are noting your achievements in terms of having the best attendance, in terms of attending all of our webinars. So congratulations to you, Samuel, and your team. PSI Lab, congratulations.
Well done again, PSI Lab.
I had the pleasure of having you present on your site performance as well at one of the webinars, and you did extremely well. So thank you for that. Napoli again is standing out. I know they already got another certificate of excellence, but they are getting another one for the greatest participation in terms of the LARC CLI webinar attendance. So Napoli and your coach, who's your coach, by the way? Congratulations, keep it up. Hopefully you can keep this up for our future quality improvement initiatives. Who's the coach
Well done.
from Napoli, by the way?
Sister Tendai Shigura.
Yes, Tendai.
Tendai. Congratulations to you, Tendai, and your team from Napoli.
Well done, Napoli.
I think this is the last one.
Okay. At Chitungwiza Central Hospital, I'm sure everybody is aware of the challenges that the central hospitals went through, especially in 2020, in view of COVID, in view of incapacitation. But in spite of all that, Chitungwiza Central Hospital stood out and they made a commitment to attend all the webinars. We would want to present them the certificate to acknowledge their commitment on that particular front. So congratulations to you, Fijani, and the team from Chitungwiza Central Hospital. Congratulations, team.
Well done, Chitungwiza.
Looking forward to handing over the certificate. Congratulations,
Yes,
Chitungwiza. Back to you, Metron.
Thank you very much. I think those are our certificates. So I would want to assure everyone that I think we'll be bringing the certificates. I think next week, what is left is to take them through to Dr. Chieza and Dr. Shungu for signing, and then we can bring them to the facilities. So I'll inform you when we'll be coming. Thank you.
Thank you, Metron. Back to you, Barbara.
Thanks, Fortunate. What an exciting day. Great work. And we were monitoring our metrics, so great to keep up with. Another photo, if you recognize anyone there, type in the chat. Any closing comments from our leadership today?
Hello, it's Dr. Mchangwa.
Dr. Mchangwa, your volume is very low.
Hello. Hello. Can you hear me now?
We can hear you, yes.
Yes, from BRTI, we have the pleasure of having a project director, program director, Levi, and would want him to say something. I'm not so sure within the leadership who else is going to come in, but from our side, we'll have Levi. I hope he's still there.
Yes, I'm still around, and thanks, Doc Mchangwa, for that.
Yes,
do I have the floor?
Opening. So I think you are the most appropriate person for BRTI.
Wonderful, thank you, Doc. Thank you very much. So Barbara, do I now have the floor to say a few words?
Yes, you do. Welcome.
Wow. Indeed, thank you very much.
Is it possible that you turn on your webcam so we can see you while you talk, please?
Exactly what I wanted to comment about. I will go ahead and do so. I was having some connectivity challenges earlier, so my bandwidth is not so good. So let's see how it goes, though. Trying. Like it's seeing me now.
Yes.
Wonderful. Thank you very much. So just to say good afternoon or good morning to us all, and to thank you as well for giving us an opportunity to say a few closing words at this point, especially for this event. It's quite an honor, I think, for me and for the lab program that we are supporting. Maybe just to start and say the the Ministry of Health Lab Program for Laboratory Accreditation and Continual Quality Improvement of Viral Load Labs is supported, of course, through the CDC PEFA, through our program at BRTI. Of course, has always and continues to promote the need for laboratories to strengthen linkages with health facilities within their catchment areas. This is obviously a very key component in the establishment of such quality management systems, including, of course, eventual international recognition. We do boast at the moment, I think, about 7 of the supported labs within Zimbabwe, Ministry of Health labs within Zimbabwe that have received such ISO or international recognition for quality. Really, these kind of linkages that are encouraged through that process are expected, of course, to ensure customer requirements for service quality are being met by these laboratories. Of course, such requirements such as uninterrupted testing, shorter turnaround time, less specimen rejections, and maybe even more predictable specimen transport scheduling, and so on. This is really the expectation of lab customers, both the clinics or the health facilities themselves, as well as our patients. But I think for a very long time, to me, my interpretation is that this has been, this has really been easier said than done. I think we can say that at this point. And I think around about a year ago or so, there was need for sort of like a flip to the next page, or a change of the gears, really, as it were, in which this process for encouraging and motivating linkages between clinics and labs to ensure the scale up is happening was sort of like nationally formalized. And this really was as a result of a number of factors, I think, including but not limited to, for example, the fact that against the requirement for universal coverage of patients on ART, I think Zimbabwe was hovering around something like 40% viral load coverage. Secondly, as well, even with this low level of testing, we also noticed that even the results utilization itself remained compromised, I think, at a number of facilities, including maybe even filing issues at facility level. I think we also noted turnaround time, which was high, something about 35 days, if I recall well, and some challenges with just the use of guidelines in management of ART patients. We also saw, I think, in certain catchment areas, rejection rates for samples which remained high. So against such a background, the need to address these issues, Ministry of Health, of course, with support from PEFA partners, including BRTI, adopted a formal program for strengthening the interface between clinics and testing laboratories to iron out and kind of, remove the creases or faults in the value chain for viral load, of course, in a collaborative manner through this QI collaborative, codenamed, of course, the Clinic Lab Interface, or CLI. It was recognized that to improve viral load service delivery, all the players or stakeholders needed to put hands on the deck together to achieve quality of viral load service. At the same time, it was recognized, I think, that the program needed to piggyback on knowledge and skills in QI collaboratives of this nature from other partners or parties in other countries or within the country itself. In this regard, PEFA supported the engagement of LARC, initially, I think, supported through PSI, and then, of course, for the past year through BRTI, is represented on this call by Barbara McKinney, who was to assist and continue to assist, I think, our teams through a structured and formalized QI program for enhancing these linkages and improving, of course, viral load service through that process. At this point, I would like to give, I think it's worth to say at this point that we should take our hats off really to LARC for this unwavering support that they offered our country teams in Zimbabwe. Even when I think at some point progress seemed to be hard to come by, especially under COVID, the pandemic. But you kept fighting. So just to give some recognition there also, we noticed there was no certificate of excellence, but I think at this point I would like to offer a verbal one as well. Kudos and thank you to LARC. Through, I think, a process of smart sessions, webinars, the IHI courses, and so on, and the aims that were chosen or selected to work on. Some 15 Harare sites, of course, have now, as we noted earlier in the presentation, been transformed as well. Measurable improvements in coverage, I think turnaround time, rejections, use of guidelines, and utilization of results have also been noted and recorded. So still, just to also say hats off to all of us, and special mention, of course, to facility teams who got their hands dirty and rolled up sleeves, really. This is really commendable indeed. Now, I think with this experience that we have gained and the successes we have seen in this collaboration through LARC under Harare sites, this cohort that we were witnessing today, the country teams are still working with LARC, aspire, of course, to go for broke this time and go the ambitious route, which is really the national route. So this has already, I think, been experimented with through an in-country rollout to 16 Bulawayo sites in the last year. And with that experience, a national rollout to achieve national impact from this important initiative, I think, becomes something that we think can still be achieved. So maybe without further ado, allow me to share my humble congratulations at this point to this team for all the work achieved to date, which I think has seen us see a lot of great successes this year. BRTI will continue this year to support our consultants, LARC, and any other lab-focused areas of support under CLI, including data, I think the IHI courses that we heard about earlier. I would like, of course, to take this opportunity to just thank Ministry of Health, site teams, CDC, our funders, the LARC again, and the other partners that have enabled this process to take place, and wishing us, I think, another year, another successful year going forward, especially with focus now on the national rollout. Thank you, and maybe back over to you, Barbara.
Well, thank you for those comments. Are there other leaders who want to end with some closing comments?
I had compiled a speech, but apparently it was plagiarized by Levi. So as Levi was speaking, I was crossing off things that I had meant to mention on behalf of ministry, on behalf of my boss, who we are lucky to have on this call. But just to reiterate, to thank everybody who participated in this earlier initiative to get things started. You're the guinea pigs. The plan is to go for broke, like Levi said. We now want to go across the whole country. So the consultants, the faculty, the project management team, most of whom could not be on this call, but I know several are actually on this call. Our funders, the CDC, implementation partners, so we have OFID, we have ITEC, we have ZimTech, we have BRTI, just to acknowledge all the efforts of the partners that played a role in this. But ultimately, I want to thank the most our coaches and the site teams that did all the heavy lifting on the ground. Without the work being done on the ground, most of us would have been planning, but to no avail. So just to acknowledge the efforts from everyone that is on the call, if we can take a second just to acknowledge all the efforts from people who made the time to be on this call. a lot of things could have gone wrong in 2020. I think I don't need to preach about how things took a wrong turn in 2020 with COVID. Some people on this call I personally know actually went through COVID. We had to go through a lot of challenges related to COVID at a personal level and at project level. We had clinic closures for different reasons, incapacitation, lack of personal protective equipment and things like that. But in spite of that, we soldiered on. We have sites that managed to attend each and every webinar. So just to acknowledge the efforts of everybody who soldiered on in spite of all the challenges that we had. We're looking forward to the consultants coming down. I personally was working on my appetite for sweets. I was preparing some answer sheets in case there are some questions that would get asked by Barbara and Katie. So I was looking forward to consuming lots of sweets in 2020, but that wasn't possible. But again, we managed to soldier on in spite of that. We innovated. We still managed to exchange experiences. We still managed to meet in spite of all the challenges. So the consultants could not come down, but they were very persistent. They soldiered on. They were very innovative in terms of helping us to continue the CLI in spite of all these travel restrictions that we all went through. So I'm looking forward to continued stakeholder engagement as we go beyond just the 15 sites and labs that were part of this initiative. So as we are taking things to scale, I want to urge everybody that is on this call to be an oasis of knowledge. So we'll have new sites that did not participate in this. They'll be reaching out to you to ask how you did it. Please commit the time to share your experiences as the experts, as the guinea pigs, as the people who started this from the get-go. So aside from being from Bire, from Baitbridge, we'll get in touch with you to try and understand how you went through this. So please take the time to share with them so that ultimately every test will translate to a transformation for all of our clients. So every client that is bled, every result will be utilized towards improving the quality of care across all our facilities and across all our whole HIV program. So with those few words, let me hand over to Dr. Mpanguri to see if she has any additional sentiments. Dr. Mpanguri, over to you.
Thank you very much, Dr. Kabo. I think after I left and your speech, I don't think I have anything else to add really, but just to continue to thank everyone else who did contributed towards the completion of this project, our LARC consultants. We thank you. Also to thank Dr. Kabo and the Ministry of Health team. They worked so hard attending all the webinars, and it was a lot of work really. And we're excited to roll out as ministry this project, just to inform the House that we have this support from our PEPFAR to roll out to all other sites, and also in the Global Fund to roll out to non-PEPFAR sites. So we're really excited, and we hope, it is our hope that this will have an impact on the viral load issues in the country. As Levi has said, that we're really lagging behind on our viral load coverage and also management of patients in a turnaround time. But I'm excited when I saw the impact of this project when Mabuku presented. So I'm really excited, even as the National ART program, we hope that we will indeed talk a different story after this project is rolled out in all our facilities. So thank you very much, everyone, all our health facilities, healthcare workers, all our cadres, all our partners. We really appreciate your support, and we hope that you continue to support this project until we see our viral load coverage at 95%. Thank you very much. Thank you.
Thank you, Dr. Mpanguri. Over to you, Barbara. I think your mic might be muted.
Okay, is any, so thank you so much to the leadership for making comments. The only thing we have, and we are a few minutes over, is just a time for a little bit of appreciative debrief. And I think
Barbara, Priska, do you want Priska to talk?
yes, I do.
So I forgot one small issue before Priska comes on as our principal funder. As we were giving out certificates of excellence, one of the notable best practice that we noticed across facilities was Second North and their notice board. Their learning board was very informative, and as a consequence of that, we'll be giving them their own certificates. We've also sent them some goodies. I hope Fijani managed to deliver their goodies on Tuesday, and we'll be visiting them early next week to do the virtual site mapping in Second North. So to the consultants, if we can identify a time when you are free, we can do the virtual site mapping with Second North early next week. And just to thank the team from Second North for setting up such a good learning board. We're hoping that when we do the virtual process mapping with them, it will be quite educational, and we'll learn a lot from going through the processes with them. So thank you, Second North. I forgot to mention that in my speech. Over to you, Priska.
Thank you, Dr. Kabo. Thank you, Katie and Barbara, for the opportunity. I think really the team has really covered most of what I would have said. But I think just to thank Katie from the International Laboratory Branch for introducing us to this initiative. And, you know, Barbara for the stewardship, I think, and the guidance. From our side, I think we really appreciate that. We had our big vision as a country, but I think your guidance really helped us to mold this into something that we could be proud of. The MOH, we can't thank you enough for leading this process. I think it would not have been a success without you being at the forefront. USAID, our sister agency, for the collaboration, and I really have to point out here that PSI really came on board at the very beginning where we were struggling with resources. Many thanks to PSI for being so proactive and moving swiftly to support this process at the very beginning. Thank you so much to our partners, ITEC, OFID, FHI 360, PSI, ZACH, BRTI. You know, it's very encouraging to see the changes on the run charts and the raster tables. It's a testament of all your hard work. You know, may this collaboration continue as we strive to sustain HIV epidemic control in this country. We hope as we continue to roll out nationally, we will be having more community partners as well on board to really take this forward. Thank you all.
Okay, just to make sure now, thank you, Priska, appreciate that. Your faith really saw us through. Is there anyone else who I perhaps missed? My apologies, Priska. You were on my list, I wasn't looking at it. Okay, well,
I think we covered all the bases, Barbara.
Perfect, very good. All right. So I just think we'll end with an appreciative debrief, and mostly you can put your appreciation into the chat box if you want to. I think you remember that on one day during the pandemic, I lit a couple of candles for the pandemic of COVID and the pandemic of racism that we were experiencing. I think you'll remember that another day I lit a candle for one of our LARC colleagues who had spoken with us at the learning session and has since passed away. And today I just wanted to close with a few more candles. And today we have multiple candles. So I'll close with a thank you for as we do this, and you feel free to type any appreciation into your coaches, for anyone, into the chat box. So this is a time for an appreciative debrief. So the first candle that I want to light is for our funders, CDC and USAID, Priska had faith when it seemed like things were not going to work. And Dr. Charles Ege came in, and Taku, so much. And then, of course, the CDC headquarters, Dr. Katie, has been my partner since 2006. So appreciate that. The implementing partners. And as Priska mentioned, PSI got us kicked off in 2019, and we're appreciative of that. And the work has just continued with BR, the TI. So thank you so much for those folks. And then all of the implementing partners, the clinical partners. And I will not mention all of them, but really appreciative to that. And then I think we are going to light another candle for the Ministry of Health. Dr. Kaba's leadership, Japhet, collecting data, we just really, of course, have been indebted to you and your work and your support. And then last but not least, I want to thank each of you. As we said at the very beginning, you are going to get out of this what you put into it. So if you invested a lot, learned a lot, practiced a lot, tested a lot, you are the better for it. If you didn't take all advantage of all the opportunities, you still have another month to get in on those IHI courses, but you will get out of this what you put into it. And you kept going through the pandemic. We kept meeting here. We were kind of like partners. We kept meeting here throughout the pandemic and kept each other kind of going, even though the times were rough. And the beneficiaries will be, of course, the clients and yourselves and your facilities. So that is my appreciation. I hope I didn't miss anyone, to each and every one of you. And feel free to type anything into the chat, your coaches or anyone that you want to say thank you to. And with that, I will leave the meeting open. So if you want to type into the chat box, feel free. And that's my final comment. Any other comments, feel free to open the mic and share it now.
I just thank you, Barbara, for your great inspiring words. I just want to make sure everyone knows that all the webinar recordings are including this one. You know, you will find them up on the our LARC website. And if you miss any components of today's important webinar, I really encourage you to go to the website and view them. Over.
Thanks, Katie. So I will sign off from here and I'll leave the meeting open for another few minutes. Anyone wants to say anything or put anything in the chat box, and thank you all. It's kind of sad, last day.
Thank you,
Thank you, everyone. It's been a very fruitful meeting. I'm looking forward to the additional discussions on how we're going to scale this up to cover the whole country. So I'm really looking forward to that, and I'm hoping we can really make it work. So thank you, everyone. Have a great day. Thank you for your time, and apologies for the 23 minutes that have gone past our allocated time, but I would like to think that it was worth every minute. Thank you very much.
Thank you.
Thank you. Bye.
Thank you, everyone. Bye.
Thanks, Chiedza. You guys were fabulous.
And thank you, Fortunate, for all your coordinating work.
Fortunate and Javed have really worked very hard.
And thank you, Japhet. You are such a genius with Excel and data.
Thank you, everyone. Bye.
Bye-bye.
Bye.
Bye, everyone.
Bye,
Bye, Fortunate.
Bye.
Bye, everyone.
Chiedza, thank you so much.
Thank you so much, Barbara and Katie.
Thank you, Chiedza.
Enjoyed the experience. Take good care and stay safe.
Thank you.
So I see folks still on here. Vijani, Coach, thank you. PSI Lab, you guys want some awards today. More PSI Lab. Seke North, you guys want an award today. NMRL Lab, I see someone on from NMRL. Good to see you all today. Teriro. Teriro, St. Mary's. Harry, Nicholas, Coach. Cephas from Seke North. Tanashi, Coach. Carol Moyo. Looking forward to next activities. St. Mary's, Hopefully. Tanashi is here, right? Coaching. St. Mary's.
Do you want to stop recording?
Yes, I do. That's a great idea. I think everyone who's typed in has typed in, so.